friends, welcome back to another interesting video. What if I told you that your knee pain might not be only a knee problem? For years we told patients three things. We looked at the knee and said it is wearing out. We looked at the x-rays and said cartilage is reduced. We looked at the weighing scale and said please lose weight. All are correct, all are true, but maybe incomplete, because a new question is now entering orthopedic clinics. Can medicines like Semaglutide, a GLP-1 medicine used for diabetes and weight management, reduces knee arthritis pain only by weight loss? Or are they also changing the biology inside the joint? In simple words, is knee arthritis just wear and tear, or is it also metabolic? And before anyone runs to the pharmacy, let me be very clear. The video does not say that take Ozempic for your knee. This video asks a better question. What does the science actually show? I may mention familiar brand names here like Ozempic or Wegovy because many viewers recognize them. But this video is about the science of GLP-1 medicines. It's not a brand promotion, not a prescription, not a medical advice. This is one single word in this whole story that separates careful science from social media hype. Stay with me. By the end, I'll give you that word. Because in medicine, hope is good, hype is dangerous. And WhatsApp University has already opened admissions for a PhD in cartilage regeneration in 7 days. So let us separate science from excitement, because knee arthritis may not be only a cartilage problem. It may also be a muscle, metabolism and inflammation problem. Let's come to section 1 in this video, the old story, less weight, less pain. For many years, the explanation was simple. Obesity plus knee arthritis means more body weight, more loads on the knee, more pain. So lose weight and knee pain reduces. That part is true. When we climb the stairs, walk fast or get up from a chair, the force going through the knee can be several times the body weight. So even modest weight loss can reduce a meaningful amount of load on the knee. This is the mechanical story. Important, but it is not the whole story, because the fat tissue is not just extra kilograms sitting quietly in a storeroom. It is biologically active. It produces inflammatory signals. It is linked with insulin resistance. It affects glucose metabolism. It affects lipid metabolism. And all of this can influence the environment around the joint. So the knee is mechanical, but the knee is also metabolic. That one sentence may change how we think about osteoarthritis. It is not only about cartilage gap, it is also about whole body in which the joint is living. Coming to section 2, the step 9, the strong human trial. Now let us come to the strongest clinical evidence. The step 9 trial was published in National New England Journal of Medicine. It studied 407 people with obesity and knee osteoarthritis. These were not people with vague knee discomfort. They had clinical and X-ray evidence of knee osteoarthritis with moderate to severe knee pain. One group received semaglutide 2.4 milligram weekly. The other group received the placebo. Both the groups received advice on diet and physical activity. And after 68 weeks, the semaglutide group lost far more weight, about 13.7% body weight reduction with semaglutide, around 3.2% with placebo. But the knee pain also improved more. The OMAC pain score improved by about 42 points in the semaglutide group. It improved by about 27 points in placebo groups. The physical function also improved more. So the first evidence-based message is clean. In people with obesity and knee osteoarthritis, semaglutide reduced weight and improved knee pain and function more than the placebo. That is strong evidence, which is randomized, double-blinded, placebo-controlled, not uncle's gym observation, and not my neighbor took one injection and now climbs Tirupati steps 2 at a time. This is a proper trial evidence, but here is the important point. The placebo group also improved. That is not a mistake. That is exactly why control trials matter. The arthritis pain naturally fluctuates. Expectations can influence pain reporting. Diet advice, activity advice, follow-up and attention can all change symptoms. So we do not compare a medicine with imagination, we compare it with a placebo. That is how we know whether the medicine added benefit beyond the background effect. But step 9 also has an important limitation. It was not designed to prove cartilage repair. It did not use a follow-up MRI cartilage measurements as a main structural endpoint. It did not deeply study inflammatory markers or cartilage metabolism. So from step 9, we can safely say semaglutide improved pain and function in patients with obesity and knee osteoarthritis. We cannot say semaglutide repaired the cartilage. Pain improvement is one question, cartilage regeneration is another question. This difference matters. Coming to section 3. Is it only the weight loss? Now comes the big question. Did the knee improve only because the patient lost weight? Or did semaglutide also calm inflammation and change the biology inside the joint? From step 9 alone, we cannot answer that fully. Weight loss is most likely a major reason for pain improvement. Less body weight means less mechanical stress. That is straightforward. But obesity-related osteoarthritis is not only mechanical. It is also linked with low-grade inflammation, insulin resistance, adipokines, glucose metabolism, lipid metabolism, and muscle function. This may explain why obesity is associated not only with knee arthritis but also with osteoarthritis in joints that do not carry body weight in the same way such as the hand. The hand is not carrying your body weight like the knee. So body weight alone cannot explain everything. Doraisame raised his hand, examined it carefully and said, "Doctor, my hand also has arthritis, but I promise you I am not walking on my hands." Exactly, Doraisame, that is the whole point. If osteoarthritis were only about load, your hands would be safe. Something in the metabolism may be reaching the joint, not just the weight on top of it. His wife Meenakshi from side says, though some mornings getting him out of bed, he does use all four. This is why metabolic health matters. A joint does not live in isolation. Cartilage, bone, synovium, muscles are all living tissues. They respond to internal environment of the body. So, if a patient has knee arthritis, obesity, diabetes, poor muscle mass, poor sleep, fatty liver, insulin resistance, and high inflammatory load, the knee is not just suffering from load. It is also living inside a metabolically unhealthy environment. And this is where the newer cartilage research becomes interesting. But also, where we must be very careful because excitement in science is like chili powder. A little gives flavor, too much and nobody can taste the actual dish. Section 4. The cartilage question, promising but early. A newer study in cell metabolism looks at semaglutide and osteoarthritis progression. It included experimental work and a small human pilot component. The headline is genuinely interesting. The study suggests that semaglutide may have chondroprotective effect. That means it may protect the cartilage cells or reduce cartilage breakdown in certain experimental settings. The study also raised the possibility that some of these effects may be weight loss independent. In simple language, the benefit may not be only because the body became lighter. There may be something happening inside the joint environment itself. So this is where the headlines becomes dangerous because the moment people hear the word cartilage, the internet starts shouting. Cartilage regrowth, new knee, no surgery, one injection. Mrs. Kamala already messaged me about this. She said, "Doctor, one injection, 6 months cartilage fully grown back like a new tire." Mrs. Kamala, the knee is not a tire and medicine is not a puncture shop. The science is promising, but promising is not proven. Sit down, let me show you the difference, I said. Yes, the biology is interesting. Yes, it gives us a reason to study GLP-1 medicines more seriously in osteoarthritis. Yes, this is promising science. But the human evidence is still very early. The pilot human data is small. It cannot yet prove that semaglutide regenerates cartilage in routine knee arthritis patients. There can be many explanations for improvement. It could be weight loss, it could be because of pain reduction, it could be because of reduced inflammation and measurement variation, a placebo effect, other treatments given at the same time, or natural ups and downs of arthritis pain. So as doctors, patients and science communicators, we should respect the science. We should be excited, but we should not overpromise. At this stage, this is a promising signal. It is not a proof that GLP-1 medicines regenerate cartilage in humans. And that is very important difference. Promising science is not the same as the proven treatment. Section 5. The cartilage is not a dead rubber. Now let us talk about the mechanism. This is where the biology becomes genuinely interesting. The study suggests that semaglutide may act on the chondrocytes. Chondrocytes are cells inside the cartilage. The cartilage is not a dead rubber. Cartilage is a living tissue. It has living cells and those cells respond to inflammation, glucose, fat metabolism, mechanical load and injury. In osteoarthritis, the cartilage cells can become metabolically stressed, They may produce more inflammatory and breakdown signals. The study suggested that semaglutide may help shift cartilage cell metabolism toward a more efficient, less stressed state. In simple language, it may help cartilage cells behave less like tired factory workers during peak festival season or more like well-rested staff after tea break. But here is a serious point. A mouse knee is not the same as a human knee. A mouse does not climb Indian apartment stairs. A mouse does not sit cross-legged at a family function. A mouse does not have a 65-year-old knee with meniscus tear, bow leg deformity, bone marrow lesions, and grade 4 arthritis. So we respect the mechanism, but we do not sell it as a cure. The real lesson is this. The knee arthritis is not only wear and tear, it is whole body biology interacting with the load, muscle, inflammation, metabolism, and aging. Section 6. The knee replacement study. Now let us look at another important study. This was a large real-world database study. The question was, are people with knee osteoarthritis who use GLP-1 medicines less likely to undergo total knee replacement? The study found that GLP-1 receptor agonist use was associated with lower long-term risk of total knee replacement. The association was stronger with long-term duration. It was also stronger with newer agents like semaglutide and tirzepatide. For patients exposed to newer GLP-1 medicines for 3 years, the 8 years absolute difference was around 4.7 percentage points. In plain language, roughly around 4 to 5 fewer knee replacements per 100 patients over 8 years. That is meaningful, but listen carefully. This is exactly where a good study can become a bad what's up forward. This does not prove that the GLP-1 medicines prevent knee replacement. It was observational, it shows association, it does not prove causation. Maybe these patients lost weight, maybe their diabetes improved, maybe inflammation reduced, maybe they had a better access to health care, maybe they followed more closely, maybe they were less willing to undergo surgery, maybe the drug directly influenced joint biology. We do not know for sure. And this is the word I promised you in the beginning. Associated is the key word here. The safe sentence is GLP-1 use was associated with fewer knee replacements, and it is not GLP-1 prevents knee replacement. One word, prevents, quietly turns a careful finding into a false promise. Associated, that is the word that separates careful science from social media hype. So the finding is important, but it needs prospective trials, some more trials, and it needs imaging, it needs pain scores, it needs metabolic markers, it needs longer follow-up, and it needs careful patient selection. Section 7. Let us be practical here. After watching this video, what should patients not do? Do not start semaglutide only because your knee hurts. Do not borrow someone else's injection. Do not buy it because one reel promised new cartilage. Do not stop moving because you think a medicine will do the work. GLP-1 medicines may become part of knee arthritis care for selected patients, especially patients with obesity, diabetes, insulin resistance, or metabolic disease. But they are not a replacement for your muscle. They are not a replacement for movement. They are not a replacement for proper medical assessment. Medicine may reduce appetite, but it cannot strengthen your quadriceps muscle. For knee arthritis, muscle is still medicine. A drug may help selected patients, but it does not replace exercises. Section 8. What patients should do. So what should patients actually do today? Number 1, if you have knee arthritis with obesity, weight reduction can help knee pain. That part is old, boring, and it's true. Second, if you have diabetes, insulin resistance, fatty liver, large waist circumference, or metabolic syndrome, improving metabolic health may help your joints too, not just your heart. Number 3, strength training is essential. Your quadriceps protect your knee, your glutes help control your hip and knee mechanics, your calf muscles support walking, your muscles improve glucose control, your muscles help reduce inflammatory load. Your muscles are not just for looking good in the wedding photos, they are metabolic organs. They are your internal pharmacy, the one you already own. Fourth, do not treat the X-ray alone, treat the person. Look at the pain, the function, the strength, the balance, weight, sleep, diabetes, and so on. Even their daily activities, their food quality, confidence, fear of movement, because the future of knee arthritis care may not be only painkillers or injections or physiotherapy or replacements. It may be muscle, metabolic health, fat loss, load management, better sleep, better nutrition, and selected medicines when they genuinely fit. Section 9, the final scientific summary. Let us line it up honestly. Entire things we discussed here, I was telling earlier. Can semaglutide reduce knee pain in people with obesity and knee arthritis? Yes. Step 9 supports that. Does that prove cartilage regeneration? No. Does the cell metabolism study suggest a possible direct cartilage cell mechanism? Yes, it is promising, but still early. Is that enough to prescribe semaglutide just for a knee? No. Did a large database study show fewer knee replacements among GLP-1 users? Yes, but it was observational. Does that prove GLP-1 prevents knee replacement? So the balanced conclusion is this. GLP-1 medicines may help knee arthritis in selected metabolically unhealthy patients through weight loss, better metabolic health, less inflammation, and possibly some direct joint effect. But they are not yet proven cartilage regenerating arthritis drugs. This is the line between science and hype. The correct message is not GLP-1 agonist regenerates cartilage. The correct message is GLP-1 medicines may reduce knee pain in selected patients and the cartilage science is promising but not yet proven. That is science without hype. The final recap with our Duraisamy, Meenakshi and Kamala. Before we close, let us bring back our three honorary reviewers. Duraisamy has been taking notes very seriously. He says, Doctor, I understood. Semaglutide helped knee pain in the trial, but cartilage regrowth is not yet proven. Excellent, Duraisamy. Then he adds, so can I buy placebo also? Because placebo also improved pain. Duraisamy, placebo is not a brand, it is the comparison group. But you have accidentally understood one very important point. Pain is influenced by many things: expectation, attention, activity, weight loss, mood, sleep, and treatment context. That is why proper trial matters. Now Mrs. Kamala enters with her phone. She says again, Doctor, one reel says Ozempic makes cartilage like a new tire. Mrs. Kamala, the knee is not a tire and medicine is still not a puncture shop. The cartilage science is promising, but promising does not mean proven. Science deserves respect and patience deserves honesty. Later, Mrs. Kamala is thinking hard and she says, so doctor, the injection is like regular servicing, not a new engine. Now you are getting it, Mrs. Kamala. Servicing maybe, new engine, no. Then Duraisamy asks the most important question. Doctor, if this injection reduces knee pain, can I cancel my walking? No, absolutely no, Duraisamy. The injection may reduce the appetite. It cannot strengthen your quadriceps muscles, your knee muscles. He negotiates and he says, a half squat? Can it at least do half squat for me? No, your strengthening exercise is still your responsibility. And his wife Meenakshi finally speaks from the side and says, Doctor, he has been trying to outsource the squat for 30 years. Finally, Meenakshi opens Duraisamy's notebook and reads, 1. Placebo, powerful, nothing. 2. Cartilage is living tissue, not tire. 3. Tea break is for cell, not for me. 4. Thigh needs responsibility. And 5. Associated, not proven. She looks up and says, actually, he understood everything. Duraisamy, very proud, says 3 jobs, still no salary. And that is the whole lesson. GLP-1 medicines may become part of knee arthritis care for selected patients, especially those with obesity, diabetes, insulin resistance, or metabolic disease. But they are not a replacement for muscle. They are not a replacement for movement. They are not a replacement for medical assessment. And they are not yet proven cartilage regenerating arthritis drugs. So Duraisamy looks at the camera and says, medicine may help my knee, but my thigh needs responsibility. Exactly, exactly, Duresh. I mean, that may be the best summary of the whole video. And Mrs. Kamala, she is now correcting her WhatsApp group. It is associated, not proven. Read properly. Good. Our work here is done. Let's come to a summary of the closing, a serious closing. For too long, we treated knee arthritis as a simple hinge problem, cartilage gap, bone rubbing, painkiller, injections, replacement. But the fuller picture is more interesting. The knee is mechanical, but it is also metabolic. It depends on load, it depends on muscle, it depends on inflammation, it depends on blood sugar, it depends on body fat, it depends on sleep, it depends on movement, it depends on the whole person sitting in front of us. So do not ask only what is my cartilage gap. Also ask how is my metabolic health, how strong are my muscles, how well do I move, how much inflammation am I carrying, how much confidence do I have in my knee. GLP-1 medicines may reduce knee pain in selected patients, especially those with obesity and metabolic disease. The cartilage science is promising, but it is not yet proven cartilage regeneration. So the balanced message is build muscle, improve metabolic health, lose excess fat safely, move better, use medicines only when medically appropriate, and do not outsource your muscles to an injection. Build muscle, improve metabolic health, move better, and age stronger. Final disclaimer, this video is for general education only. It is not personal medical advice. I have mentioned several familiar brand names such as Ozempic or Wegovy only because many viewers recognize them. This is not an endorsement, advertisement, or promotion of any brand. The science discussed here is about semaglutide, tirzepatide, and GLP-1 medicines as a drug class. Please do not start, stop, borrow, purchase, or change any GLP-1 medicine based on this video. These medicines have proper indications, contraindications, side effects, cost considerations, and require medical supervision. Please discuss your knee pain, diabetes, obesity medicines, and treatment options with your own treating doctor before making any changes. Thank you for watching. See you in the next video. Goodbye.